on targeted and personalized cancer nanomedicine. And again, it's my pleasure to welcome the first speaker. That's Simo Schwartz from Barcelona, and he will give us an introduction into cancer stem cells. So we are really curious. And as seen yesterday, it elicits quite some extensive discussions, so we are looking forward to that.
Well, thank you very much. I'm going to keep talking like yesterday about the cancer stem cell focus. For those of you, well, this is the title of the talk, so how we can target cancer stem cells and whether this might be a good idea in terms of providing new therapeutic strategies. No? For those of you who were not here yesterday, let me just remind what's a cancer stem cell. So we're talking about a subtype of a very specific subtype of cell, which is a subset of cells that you will find in any solid tumor or in any tumor cell line, which is, and any commercial cell line will have the same thing, which are responsible of first generating the whole tumor. So the assumption in tumorigenesis is that these cancer stem cells come from normal stem cells who accumulate mutations and epigenetic changes, and they transform they go into a malignant transformation, and then they rise up these cancer stem cells who, in turn, will give rise to the whole solid tumor, and eventually will also be able to spread the disease to the rest of the body. So these are the cells who have the capabilities of metastatic spread. Why? Because they have this capability of survival in non-adhesion conditions. So most of the cells, when they detach, they die. There's a special cell death program which is devoted just to be sure that any cell in the body who detaches, except the hematological cells, but for the rest of them, they are programmed in a way that if they detach, they have to die. No? So these cells learn how to avoid these processes because they block. It's not that they block; it's that they overexpress some very specific pathways related to this adhesion. No? So they survive. In other words, these cells are capable of doing metastasis because they think. Allow me to use this expression. They think that they are attached. So why is this important? Because when you treat cells with standard chemotherapy, in most of the cases, not in all the cases, but in most of them, what we're seeing is that we're capable of killing the cells, the tumor cells, but not the cancer stem cells. No? So at the end, you might end up thinking that the therapy is working perfectly when that's not really the case. No? So if you have this situation, what's going to happen is that at some point the cells will regrow the tumor or will drive the metastatic spread. No? The solid tumors normally is not a problem because the surgeon will come and will remove it in most of the cases. So this is not going to happen with the solid tumors, but it will happen eventually with the metastasis. No? So obviously the hypothesis here is that if we can get rid of these cells, then we will be able to really get rid of the tumor or at least the metastasis, which is what really kills the patient. So how can we target these cells? Fortunately, we know that most of these cells have some specific surface receptor markers that might allow us to identify them, as also to isolate them, and therefore we might be having a chance to target them thanks to these surface receptors. No? Some of the receptors are like these ones we have here, like CD133. Most of them are adhesion receptors like CD44, CD133, and so on. And one interesting thing is that you will find these cancer stem cells in most of the cancer cells. So we have decided to use this one of here, CD44, as the one we use for selecting, isolating these cells and also for targeting those cells, no? Just to try one of them. It's true that this receptor is not exclusive of cancer stem cells because up to now we don't know of any specific receptor which is just found in cancer stem cells, but it's quite useful, as you will see. So What you see here is a fax data. This means that every dot here represents the cells, so we can separate cells according to the levels of CD44, higher levels here, lower levels here, and CD24, same thing, lower levels here, higher levels here. So this is the representation of these cells, of the MDA MB231. This is from mammary tumor cells, and MCF7, which is another mammary tumor cell line. No? So these are the sections that we are interested in. No? Those cells here which have, those cells here which have a high level expression of CD44 and low of CD24 are in theory to be the cancer stem cells. This is what's known. Same thing here. High levels of CD44 but low of CD24. So these cells here and these cells here, the ones that we want to have. No? If you check the levels of CD44 in different cell lines, all those cell lines are from breast. You'll see that there's some cells with a high level of expression, some others with lower level of expression. So this normally represents that in these cells, at least in theory, that's the hypothesis, they have different numbers of different percentages of cancer stem cells. It is also true that this is not perfect. So often what you have, if you try to isolate the cells using this CD44, is that you will have the cancer stem cells, but you will probably also have a lot of tumor cells which are not cancer stem cells. No? But it's a way to isolate them. At least it's the way that it has been used until now. No? We were interested into knowing whether we were able to use some drug delivery systems against these cancer stem cells. So the idea was to use a system. In this case, this is one of the systems that we test from the group of Rogerio Gaspar and Mafalda Videira. It's PLGA with PEG and paclitaxel. We had this system with and without the CD44 receptor, and we test them on our cells. No? This is internalization study. So what you see here is for these two cell lines, at 24 hours and at 72 hours, how this system internalized. No? So in order to make it easy, those are cells without the drug delivery systems in black. When the system gets inside, the figure goes to the right. No? So these cells here represent cells that have internalized the system. In this case, the PLGA PEG with the fluorochrome. Okay? Same thing with the MCF7, in which, as you can see already, the internalization is more difficult. No? It goes slowly. Probably this is related to the endocytosis capabilities of those cells. No? 22 hours is a little bit different, and MDA231, it already has internalized the system, and what it's more interesting here is that if you check this red line, this is showing you what happens when you add the CD44 receptor, the CD44 antibody against the CD44 receptor on the system. So the internalization gets much faster, and the number of cells which internalize the system is much higher. So it means that the system might be favoring the internalization if you use the CD44 receptor. No? And this is the same thing, but is in images. So well, this is the fluorochrome, this is the system, these are the lysosomal organelles, and here is where they colocalize. So it means that at least in this 231, the system was capable of internalization, of internalizing. Let me switch a little bit to another concept, which is how we have designed a system to isolate and characterize these cells without using the CD44 receptor. Aldehyde is an enzyme which is active in cancer stem cells and in stem and progenitor cells. This is already known. No? So cells use this aldehyde dehydrogenase for some metabolic activities. No? Among them, it seems that it controls the expression of some genes. Among them, is involved in the synthesis of retinoic acids, and also seems to be useful for stem cells to protect them from toxic aldehyde. So, and there's a bunch of solid tumors and also blood cancers that have high levels of show high levels of aldehyde. No? More on this. It has been shown recently that aldehyde it correlates with the overall survival in human tumors and also in the response to treatment. So the higher the levels of aldehyde, the worse it goes, the overall survival. This is what you see here and here. So tumors like those here, tumors that have very high level of expression of aldehyde, tumors like those here have lower levels of aldehyde, so overall survival is better. And the same thing if you check with tumor resistance. So those tumors who are resistant to chemotherapy, they express aldehyde, which is this one here. So there's a correlation, an association between aldehyde expression and cancer stem cell status. Okay, so we use this in our advantage, and we designed this vector, which is a vector that expresses this tomato. This is a fluorochrome that gives you this red color to the cells, and under the promoter of the aldehyde. So the theory is that if you put this in a cell and it's a cancer stem cells, this promoter will be active. It will activate the tomato expression. You will see it in red color, so we'll be able to distinguish cells according to the color, whether they are cancer stem cells or tumor cells which are not cancer stem cells. No? This is one of the tests that we did. So if you introduce this in the cells, you isolate these red cells and let them grow. They do this round conformations. These are mammospheres. These are tumor spheres, so they grow like spheres. And if you take them and you let them grow then in attachment conditions, you can actually count them. No, it makes easy as to control this population. So you do this with cells which are red and cells which are not red. So let's say that these ones are the cancer stem cells. So you have much more number of mammospheres than if you use the negative one. Why is this? Because the system is not perfect, so you always have a little bit of cancer stem cells in the population in which you're not seeing a color, no? But it works quite well, no? Same thing if you check about markers. So you will see that CD44 is there, aldehyde 1 is there, CXCR1 is there. This is expected, lower level of CD24, that's also expected. Same thing if you go to other markers like OD4 is also overexpressed. If you compare the red cells with non-red cells, for instance, same thing in different cell lines. And also if you check for mesenchymal transition genes. These are genes that are involved in the stem cellness of a cell. So these are the ones that will give the cell the capability of metastasis, of growing in non-attachment conditions. And you see the BMNT trees, for instance, are overexpressed, whereas E-cadherin are underexpressed. This is expected. No? This is what you would expect from a metastatic cell. No? If you take these cells and you let them grow in attachment conditions, you will see that very soon they start giving rise to other cells like those ones here, which doesn't have the red fluorochrome. This is because cancer stem cells are supposed to do this. No? They grow, but they immediately give rise to tumor cells which are not cancer stem cells. So at some point you can reproduce the whole tumor, which is what you see here. From all these cells, if you let them grow, few are still the cancer stem cells from the beginning, but then the rest are losing this capability. No? So if you, in order to test our system, what we see is that if you use, this is a comparison on the PLGA PEG with paclitaxel, compare with the PLGA PEG, paclitaxel CD44, and without the antibody against CD44. To make it easy, and what we see is that paclitaxel and the systems are showing efficacy at some concentrations. No? Obviously, paclitaxel is more efficacy, shows more efficacy in vitro than the complexes, than the systems. But both of them show efficacy. So, but what we're seeing here is what happened when we test the whole cell line. So we're killing cells. We're not sure whether we are also killing cancer stem cells. So when we check what happened with the cancer stem cells, and we measure the relative concentration of red cells versus non-red cells, what we're seeing is that if we use paclitaxel, the number of red cells and the cancer stem cells rise. It's not that the absolute number rises, no. It's that the proportion changes. So you're killing more tumor cells than cancer stem cells, much more. So at the end, you're doing what we comment on the first slide. So you basically clean tumor cells, but non-cancer stem cells which are much more resistant. So just when we test the system, however, using the drug delivery systems, what we saw is this, and here we're counting mammosphere formation. So we're seeing that paclitaxel is capable of killing some of them, but if you use PLGA-PEG paclitaxel, or even if you use PLGA-PEG CD44 receptors paclitaxel, and in this case this is more obvious, you reduce the number of cancer stem cells. So what this is showing you is that by using paclitaxel alone, we're killing cells, but we are killing preferentially non-cancer stem cells, or let's say tumor cells which are not cancer stem cells. But if you use this system here, the sensitivity of cancer stem cells to the treatment gets much more higher. So the cancer stem cells are much more sensitive to the treatment if you use drug delivery system. So for some reason that we still don't know, the use of drug delivery systems will increase the sensitivity and the response to treatment of these cancer stem cells. No? And I'm going to stop here because I don't have much more time, but I'll be glad to answer any question you have. Okay. Sure.
Yeah, thanks a lot for the nice presentation. Are there questions from the audience?
Just one quick one. I know you choose CD44 and you said it's an adhesion receptor. What would happen if you actually had some extracellular matrix present in the mammosphere or then in vivo when it is actually bound? Mm-hmm. So if you choose another receptor which is more internalizing, I guess you get better results.
Yeah, sure. This was just, this is an essay that we did a preliminary data just to see so the idea here was to show that if you use a drug delivery system, you can overcome the resistance of cancer stem cells. And that's, I think it's clear that it's happening. No? The other question is CD44 the right target for going in vivo? Probably not. Question is that which is the right target for cancer stem cells? And this is something that is not yet known. No? So at least now we have the chance to isolate these cells and to study them and see if we can find a better targeting. No? But we'll see that in vivo. Because we're going in vivo with this, but we'll see.
Yes, please.
So does cancer stem cell express the cancer testis antigens? Are they target of cytotoxic T cells?
If your question is if they express
cancer testis antigens which can be targeted by cytotoxic T cell response?
In theory, yes. What is known is that the cancer cells, and probably cancer stem cells, are capable of inducing a very specific tumor environment, which is inducing macrophages to change the way they normally act. So put it in a simple way, is like if these cancer stem cells are capable of telling the macrophages and the immunological system that, hey, don't touch me, I'm a good guy. So, and the macrophages, when they go inside the solid tumors, they change, and then they begin to produce some growing factors that, in fact, help the system to grow. Yeah?
Okay, thank you very much again.
Sure. Thank you.
And